Good. So it's 7, Dr. Nidhi, we can start.
Okay. So good evening, everyone. I, Dr. Nidhi Gupta, professor at Hamdard Institute and JC of ISCCP, on behalf of ISCCP, welcome you all for this interesting webinar series of 70 minutes at 7 p.m. on 7th of every month. As tradition, I invite Dr. Aruna Nigam, our president, for the welcome address. Over to you, ma'am.
Thank you, Dr. Nidhi. A very good evening to all of you. It's so good to see all of you. One thing which we have started and it's going on so successfully. All it's because of you. And every meeting I have a tendency to announce something. So today also I have something to announce for all of you. I want all of you to work on some thing on cervical cancer. So let me share my screen. Yeah. Is it visible to all of you?
Yes, ma'am, it's visible.
Yes, ma'am.
Yes. Okay, so this is a reel making competition which we are going to introduce tomorrow. You all will have all the details in the WhatsApp group, as well as we are going to send everything on the mail also. This is a reel making competition for HPV vaccination to prevent cervical cancer. And why we are introducing this, because one of the dispensary near to my hospital of government is catering towards the free vaccination. But to our surprise, it has been started in February 28th, and it's March, April, May, June, July, 4-5 months, and hardly they could vaccinate only 5 people. So something is missing. So we have to work together. So I thought, let's make reel. And then whatever reels are good, we are going to publish them on different social media to have a more knowledge about this cervical cancer awareness and HPV vaccination. So we have already gone through all the essential things regarding this reel making competition, and we, along with Narchi Delhi, and we have included the very important society, that is a MBBS student society, because they are going to take it to the medical students also, young students, very much enthusiastic in making reels and everything. So we have taken their help to make this reel making competition, and there are all the rules for the submission are ready, how entries will be scored, who will be the judges, and there will be 3 categories for the same. Number 1 will be the MBBS students and interns. Number 2 will be the postgraduate students and the practitioner, in which all ISCCP member comes. And number 3 will be for the nurses and other healthcare workers. So 3 categories will be there with the attractive prizes, as you can see. So everybody has to participate in this. Whatever ideas you have, that has to come out of your mind so as to help the society, right? So all the information will come to you. So this is another event which is being introduced by the ISCCP this year. So thank you all, and thank you, Dr. Nidhi, and I thank you, Dr. G.S. Jyoti, for taking on this today's webinar of 7th of this month. Thank you. Let me stop sharing.
Thank you, ma'am. Such an interesting competition. So without taking more time, I handed over the platform to Dr. Jyoti GS, who is the convener of today's webinar. Over to you, ma'am.
Thank you so much. Good evening, one and all. At the outset, I thank Dr. Aruna and the team for giving me this opportunity. And even without much ado, I want to introduce Dr. Tara, who will take over this and facilitate this by being the MOC. And she is the senior consultant obstetrician gynecologist at HAL Hospital, Bengaluru. Over to you, Tara.
Thank you, Jyoti Madam, for the kind introduction. So now let us move on to the webinar, the theme of which is biomarkers in CIN, from microscope to molecules. I would like to invite our expert for the first to talk, Dr. Veena P., who is the professor and unit head, Department of Obstetrics and Gynecology, and who is the faculty for MCH Gynae Onco at JIPMER Pondicherry. The first speaker for today will be Dr. Jyoti GS, who is professor and head of the Department of Obstetrics and Gynecology at Ramaya Medical College. She will be speaking on Biomarkers Unplugged, what every gynecologist needs to know. Over to you, madam.
Thank you so much. I'll be sharing. Can you see my slide?
No, ma'am.
No?
No,
The
ma'am.
slide's not
No.
visible.
Just now I...
Madam, click on the share button.
Yeah, that's what.
Have you clicked on the share button, ma'am?
One minute. I'm just not getting it.
Can you see the share button, ma'am?
No, I've just come out of it. That's why I don't know.
Basically, ma'am, it's because everything must be try to see where you can mute or unmute. Next
Yeah,
to that
now
is
I
the
came. Now I came. Where is the share button? Is there, sir?
Yes,
It's
ma'am, it's
here.
near to
Ma'am,
Yeah.
in the
Below.
lower panel, you have
Yes,
an
Lower
up
Yeah,
arrow.
I saw, madam.
Sometimes it just gets hidden when you don't go the mouse over it.
Yeah, it sometimes goes away.
Yes, ma'am. Now you have to
Yes.
go to the PPT and slideshow
Yeah.
mode. It will perfect, ma'am. Do
Yeah,
the
I think we
slideshow.
can see the PPT.
Yes, ma'am.
And are you seeing
Yes.
it now?
Perfect, ma'am.
Yes,
All
ma'am.
good,
Yeah,
ma'am. You
yes.
can start.
Yeah, sorry for the time. Okay. Good evening, everyone. My today's talk will be on biomarkers in CIN Unplugged. So let me see, I will be very fast and I will be telling few points about each biomarker. We know the cervical cancer burden in our country. After breast cancer, cervical cancer is the second most common cancer in women. And most of more than 99% of the cases of cervical cancer is caused by human papilloma virus infection, and we have identified 14 oncogenic strains of HPV virus. Now, why do we need biomarkers? We know that most of the CIN1 and CIN2 lesions regress. It is only 1% of the CIN1 lesion and CIN1 LCIL, and 5% of CIN2 and 12% of CIN3 which progress to cancer. So, in order to identify women who are at high risk of cancer, and to look and to see and to observe the patient who do not need over treatment, the biomarkers are very, very helpful. So, while primary HPV DNA screening is more sensitive than cytology, there is a need for effective triage to distinguish between transient infections from clinically significant disease. So, for this, it is important for us to know about the HPV virus. A HPV virus is a DNA virus which is double-stranded, and it has got the structure of the HPV virus is that it has early genes, E1, E2, E4, E5, E6, E7, and L1, L2 genes. They are the capsid protein genes which cover the virus, which are very important. So, how does this HPV cause cancer? When the viral DNA gets incorporated into the cervical epithelium, inside the DNA of the cervical epithelium, then the process of carcinogenesis happens. That is a high risk virus. Persistent infection with HPV high risk virus. So, for that to understand, we need to know the cell cycle. The cell cycle has G1 phase, S phase, G2 phase, and mitosis phase. And we need to know that we have two tumor suppressor genes. They are the retinoblastoma gene, and the other one is the P53 gene. So what happens when it gets when the viral DNA gets incorporated into the cervical epithelium, into the DNA of the cervical epithelium, then there is this tumor suppressors are dysregulated. So first of all, the E6 and the E7 viral genes are very, very important. The E7 goes and breaks the barrier attachment of the retinoblastoma gene with the E2F, which is a transcription factor. So as a result of this, the E2F levels increases. When the E2F levels increases, it is a transcription factor. There is it by negative inhibition, the P16 values will also increase. So when this happens, the tumor suppressor effect of the retinoblastoma gene is suppressed, and the patient and the cell cycle continues to S phase, where it starts proliferating. So when it starts proliferating, we have two proliferative markers, MCM2 and TOP2A. They are proliferative markers, which is essential in the S stage for cell proliferation. And also we have one more factor, that is the Ki67, which also increases. So both these factors, they are proliferating markers, which is P16 and Ki27, which increases, and as a result, the cell goes to the S phase and starts multiplying. This is about E7. When you come to E6, E6 binds to P53, which is also a tumor suppressor gene. And so the suppression effect, the oncosuppression effect of P3 is also lost. And so they go towards further multiplication into G2 phase and cause mitosis. So this is very important for us to know. So what are the biomarkers? The biomarkers are the molecular biomarkers, the protein biomarkers, the cellular biomarkers, the methylation markers, and few other biomarkers which I'll be telling you, which is of huge interest for us and where research is still happening. When we say molecular HPV biomarkers, we mean to say that we are looking at the virus. What virus? We are looking at the high-risk HPV DNA virus, or we are looking at the high-risk HPV E6, E7 mRNA virus. So this is done by molecular test. And the other thing is looking at the proteins of the HPV. They are which proteins are we looking at? HPV L1 capsid protein, and looking at the E6, E7 protein. This is done by immunohistochemistry. The next is the cellular markers, where we look at P16, and where the E2F factor by negative inhibition, as I told you, raises the level of P16, and Ki67. Ki67 also rises along with that. It is a proliferating markers, as I said, P16 followed by Ki67 and TOP2A and MCM2, which are both needed in the S phase for cell proliferation. And we have methylation markers. WHO has recommended HPV DNA testing as a primary test for cervical cancer screening. HPV testing, though it is more expensive than cytology, it is more sensitive, but it has a low specificity, and a positive result cannot discriminate between transient and persistent HPV infections. Despite these limitations, high-risk HPV testing is still beneficial, especially for diagnosing atypical glandular lesions and adenocarcinoma, which are often missed by cytological methods. So what is this? Next is the HPV genotyping. In patients with positive high-risk HPV results and normal cytology findings, instead of waiting, we can do this HPV genotypings. So this HPV genotyping will help in categorizing the risk levels associated with HPV infection, such as individuals with HPV 16 or 18 infection are at higher risk and they potentially require more aggressive monitoring or treatment. These are the FDA approved HPV kits. We have the hybrid capture 2, the Cervista, the Cobas, and the BD on clarity, which are all the DNA test kits, and we have the Aptima, which detects the mRNA, and all these have high sensitivity, but the specificity are moderate. But because as compared to Aptima is the best, which has the better specificity as compared to the other DNA methods, DNA kits, because here instead of detecting DNA, transcription has happened and it has been converted to mRNA, and that is more specific. So looking at these kits, the Cobas and the BD on clarity is the one which is used for HPV DNA screening, and the hybrid capture and the Cervista usually we use it for triaging, and when we have to do when there is ambiguous result, then to look into the actual what is happening. So the next thing is the detecting the L1 capsid protein by immunohistochemistry, and L1 capsid protein forms a protective cover for all viral gene material, and here it is a nuclear expression. HB1L1 capsid protein is found in mild to moderate dysplasia, but what happens as the lesion progresses, this gets dysregulated and it is lost in higher grade intraepithelial neoplasm, because when there is integration of the viral DNA with the human genome, this disruption of the L1 gene occurs, and hence there is loss of protein expression. So when you see in the slide, initially you see the magenta color, which is seen in mild and moderate dysplasias, but when the patient goes into HCIL, you can see that this is lost. So it could be a possible prognostic marker to identify early dysplastic lesions, most likely to progress to high-grade lesions. And E6, E7 oncoprotein is the next biomarker. It has a lower cost, broader applicability in pathological practice, and it is essential for identifying high-risk individuals, which will be dealt in detail in the panel. So the next important IHC marker is the P16 and the Ki67. So we have told how the P16 levels rise, and the Ki67 and the MCM2 and top 2A or the proliferative markers in the S cycles that also increase. So when you look at the background, P16 immunostaining serves as a surrogate marker to establish high-risk HPV status, and it identifies oncogenic transformation. It is FDA approved and it stains both the nucleus and the cytoplasm. So when we say P16 positivity, means it is block positive. More than 2/3 of the cells will get stained brown color, then it becomes P16 positive. And then Ki67, as I told, it's a proliferative marker, and all these are they are helpful for triaging of equivocal cytological findings such as ASCUS, and to identify abnormal cells in cytology preparation. It also helps us to differentiate between LCIL and HCIL, and improved identification of women with high-grade lesions as compared to cytology alone, and triage of HPV positive women when cytology is negative. So we have a dual stain. It is called a Syntec Plus, and it is cheap, easy to use method, and it is conducted on SurePath LBC sample, so preventing the need for biopsy, and the sensitivity of P16 Ki67 dual stain for confirmed CIN2 is 92.2% for ASCUS and 94.2% for LCIL cases. And they, as I said, they also help in distinction of HCIL from its mimics. such as atrophic squamous epithelium or transitional metaplasia and squamous metaplasia. Another important thing of Ki67 is it aids in the evaluation of cauterized cervical resection margin by distinguishing between HSIL and non-dysplastic epithelium. You can see this dual stain of P16 brown in the cytoplasm. Ki67, it is only nuclear staining it is, and normally it stains the basal and the parabasal cells, but if there is high grade lesion, it will stain the whole cell as whole length brown. So the other marker, as I've said, which is essential in the S stage of the cycle for proliferation, is the MCM2 mini chromosome maintenance marker. It functions in the early stage of DNA replication because the DNA has to multiply. So this helicase DNA, it helps to unwind this duplex DNA during the synthesis, and dysregulation of this appears to be an early event in the tumorogenesis. And inappropriate expression of MCM27 is found in a variety of pre-malignant dysplasias and cancers. TOP2A, topoisomerase 2 alpha, it's a nuclear enzyme responsible for relaxing the coiled DNA during replication and chromosome condensation. And this expression is associated with progression from SIN2 to advanced cervical neoplasia. We have this BD ProXC kit, that is a protein-based biomarker reagent from BD Diagnostic, containing antibodies to both these proteins, MCM2 and TOP2A. And when you combine this P16 with this BD ProXC, when you analyze, then you get the highest sensitivity that can be detected, that can be stained for CIN2 and CIN3. So the other thing is just upcoming, it is the microRNA. MicroRNAs are short strands of non-coding RNA, and certain microRNAs can operate as oncogenes or tumor suppressing genes to inhibit the expression of cancer-related target genes. And when you look at all these, when you see the low-grade lesion, Ki67 stains only the lower third, high-grade you stains diffusely, and as such it will stain the basal and the parabasal cells. P16 also low-grade focal patchy and diffuse block positivity in high-grade. BD ProXC also focal patchy and diffuse or strong brown color stain. And as we say, HVL1, it's reverse. High expression is seen when L1 is present in low-grade dysplasias, and loss of expression due to integration in high-grade dysplasia. And coming to methylation markers,
Dr.
DNA
Jyoti, sorry to interrupt.
Hypermethylation is a chemical modification
Dr.
of
Jyoti?
DNA where methyl groups are added to
क्या बोले
function of cytosine, resulting in gene
Hello?
cytosine of specific regions.
Hello?
Yeah.
Hello?
Yeah. Specific regions of DNA. In cervical cancer, DNA of the HPV as well as the host may become hypermethylated, and the methylation pattern changes as the virus progresses from an initial infection to causing cancer. So the benefits is it can be used to triage a positive high-risk HPV test on the same LBC sample reserve, and it can be used as a confirmatory test in women with astrocytology and identifies women who would benefit from immediate treatment and who need monitoring. It is still research is being done and being refined, and as it evolves, it becomes a valuable tool for improving the accuracy of cervical cancer.
Madam, kindly sum up because it's already almost 20 minutes.
Then we have the immune biomarkers for cervical cancer treatment. That is the where we have this will help, because this will help us there are certain drugs. We have PDL and PDL1, which binds on lymphocytes and the cancer cells, and antibody blockade of these cells will reverse the process and enhances the tumor immune activity. Circulating serum biomarkers are elevated squamous cell carcinoma antigen. They're not specific for for cervical cancer, and they can be seen in other tumor and non-malignant conditions. And we have the squamous cell carcinoma, CIFRA21, which is elevated in 42 to 52% of patients with squamous cell carcinoma of the uterine cervix. Another very important future biomarker is the liquid biopsy, where you take, that is the blood of the cancer patient. You can detect and isolate circulating DNA, tumor cells, RNA, extracellular vesicles, which is released by lysis of lymphocytes and tumor cells in the bloodstreams. So the learning point is the WHO recommends the use of HPV DNA test with or without cytology as a part of cervical cancer program. High-risk HPV genotyping and viral load assessment are proposed as triage markers for women with positive HPV DNA test results or negative cytological findings. E6, E7 mRNA-based assays have shown higher specificity, potentially complicating traditional screening methods for borderline or low-grade lesions. And triage and risk assessment offers great advantage in clinical setting, leading to more personalized treatment. And dual staining by P16 Ki67 has proved useful for diagnosing cervical dysplasia and cancerous lesions, and distinguishing from histological mimics. Newer biomarkers such as MCMI5 and TOP2A offers maximum specificity for SIN2 and SIN3 when used in combination with P16 and Ki67. SECAG is a prognostic marker. Upcoming microRNAs have also gained importance in their implication in gene silencing and carcinogenesis also. And PD1 and PD-L1 inhibitors have also found to be valuable in treating advanced or recurrent cancer, and their detection may be valuable in managing advanced stage cervical cancer. Thank you so much for your patient hearing.
Thank you, Dr. Jyoti, for the extensive, elaborate discussion on biomarkers. We would now move on to the next talk, which is a debate on biomarkers in cervical cancer screening. Dr. Nandish, who is an assistant professor at Sri Madhusudana Sai Institute of Medical Sciences, would be speaking for the use of biomarkers, that is, their usefulness and clinical necessity in cervical cancer screening. Over to Dr. Nandish.
Sairam, very good evening to one and all. I'm audible?
Yeah, you're audible.
Yes, you're audible.
Okay. Very good evening to one and all, the respected chairperson, esteemed faculty and delegates, and my worthy opponent. Today, I am here to speak about the biomarkers in cervical cancer. Is it a boon? I am Dr. Nandish, who is working in Sri Madhusudana Sai Institute of Medical Science and Research Center. This is in Chikbalapur, Karnataka. Today, I rise to strongly support the motion that biomarkers are boon in cervical cancer. Imagine treating every woman with cervical cancer in exactly the same way without knowing who is at risk, who will respond to treatment, who may relapse, or who may benefit from the immunotherapy. That was a reality a decade ago. Today, biomarkers are changing that reality. Biomarker is not just a laboratory test. It's a window into a biology of cancer. It tells us how the tumor behaves, how aggressive it is, and how we can tailor the treatment for individual patient. Hence, in this era of precision medicine, biomarkers have become indispensable. So I have got 5 reasons to say why biomarkers are truly a boon. Among them, the first reason is biomarkers improve the screening and early detection. The greatest strength of biomarkers lies in identifying the disease before invasive cancer develops. We all know that traditional pap smear rely on subjective interpretation and have variable sensitivity. Thus, biomarkers improve the accuracy of detecting clinically significant lesion, especially with the other high-risk HPV positive. Hence, it is an acceptable triage option as per the 2026 WHO recommendation. For example, we all know that cellular markers P16 and Ki67. So in combination, it is called dual staining, has significantly improved the detection of SIN2 and SIN3. Dual staining sensitivity is 94% and specificity is 93%. When we see the specificity of HPV itself, HPV DNA is less than 93% of dual staining. Hence, the WHO recommends a dual staining for HPV positive women with no or limited genotyping, for non-HPV 16 and 18 positive women, and for the HPV positive women with pap smear showing NILM. The advantages of having this biomarkers will help us in early diagnosis of high-grade lesion, and this reduces the colposcopy and other invasive procedure. And we can also have in better counseling because risk can be explained biologically, and this improves overall of our patient's care. My second reason why I say biomarkers are boon, biomarkers enable the risk stratification. Not every HPV infection progresses to cancer. In fact, nearly 90% of HPV infection clears spontaneously. The real challenge is that identifying that small group of 10% women who are at genuine risk of progression. Thus, this biomarkers helps us to distinguish between the transient HPV infection from the persistent, and in the precancer condition, like differentiating between SIN2 and SIN3. For an example, we have E6 and E7 mRNA viral load assessment. So these tests help to identify women requiring closer surveillance while reassuring those who are at lower risk. Thus, the biomarkers helps to avoid both over-treating and the under-treating. My next reason is biomarkers guide the precision medicine. Cancer treatment is no longer one size fits all. Biomarkers allows us to personalize the therapy. For such example, we have got very good example, that is PDL1 expression, that is immune checkpoint markers, which are programmed cell death ligand 1 expression. So that patients with PDL1 positive, recurrent or metastatic cervical cancer may benefit from immune checkpoint inhibitors such as pembrolizumab and nivolumab. Without biomarker testing, these patients would never receive potentially life-prolonging immunotherapy. Similarly, ongoing research on circulating tumor DNA, tumor mutational burden, and genomic profiling, all these promises making the individualized treatment. This is the precision oncology in action. The fourth one is the biomarkers predict the prognosis. Biomarkers helps to answer the crucial clinical questions like, will this tumor recur? Is the patient likely to respond to treatment? Who requires the closer follow-up? For an example, as I've already told, that PDL1 is more than the predictive marker for immunotherapy, and the upcoming serum markers such as squamous cell carcinoma antigen, CIFRA, correlate with the tumor burden and treatment response. The advantage of having these markers will help us to know the persistent elevation after the therapy may indicate it's a residual disease or early recurrence. This allows the clinician to intervene before the clinical relapse becomes evident. My other example to this is in molecular biomarkers, we have HPV6, E6 and E7 mRNA. The persistent expression of this HPV E6 and E7 oncogene indicates biologically active infection rather than transient HPV carriage. This identifies the women with a lesion that are more likely to progress, thereby refining risk assessment and prognosis. Therefore, biomarkers are not only diagnostic, they are the powerful prognosticating tools. My last reason will be biomarkers accelerate the research and innovation. Many of today's routine tests were yesterday's research discoveries. The same applies to the cervical cancer. The current biomarker research in driving in liquid biopsy, circulating tumor DNA, microRNA profiling, artificial intelligence and assisted diagnostics, genomic sequencing, these innovations promise early diagnosis, use of minimally invasive monitoring, and truly personalized treatment. Therefore, every breakthrough begins with the research, and the biomarkers are leading this revolution. By giving these 5 important reasons, I can again say that biomarkers are truly boon for the mankind. Thank you.
Thank you, Dr. Nandish. So now let us hear Dr. Tejaswini, who's an assistant professor at Bangalore Medical College, who will be speaking against the motion. So she will be speaking about, is it overused or is it only an academic luxury on using biomarkers in cervical cancer screening. Over to you, Dr. Tejaswini.
Am I audible?
Yes, you're audible.
Good evening, respected dignitaries and my dear friends. Every few years, medicine gives us a new promise, a newer biomarker, a newer molecular test, a newer technology. As clinicians, we must ask one question. Does this innovation truly improve our patient care, or are we simply impressed by the innovation itself? Today, I stand to argue here that while biomarkers in cervical cancer screening are scientifically fascinating, their routine clinical use remains more of an academic luxury than a clinical necessity. First and foremost, cost effectiveness of biomarkers is unproven. Biomarker tests increase the healthcare cost without proven potential clinical benefit. Many regions, particularly in low and middle income countries, struggle to achieve basic HPV screening coverage. Adding expensive biomarkers widens the gap. As we all know, India accounts for about 1 in 5 global cervical cancer cases and about 25% of cervical cancer deaths. If only 2 out of every 100 eligible women are being screened, adding another sophisticated biomarker does not solve the remaining 98. Technology cannot compensate for poor coverage. Next important question is that do biomarkers change the management? In many settings, hysterectomy remains one of the most commonly performed gynec surgery. For women who have completed the families, many choose definitive treatment rather than prolonged surveillance. Even the report I have mentioned here article also suggests us the same. Also, most importantly, there is no evidence to say that biomarkers reduce the cervical cancer incidence or mortality. So a test should improve outcome, not merely improve risk stratification. One of the biggest challenges with biomarkers today is the lack of standardization. Numerous new biomarkers are entering the market. Each promises better risk prediction, but none has emerged as a universally accepted gold standard for cervical cancer screening or management. So are we adopting this test because they consistently improve the patient outcome or because they are newer and heavily promoted? One of the major arguments in favor of biomarker is that they reduce inter-observer variability among the pathologists. In theory, that's true. But what happens in real practice? Immunohistochemistry itself is not a simple test. It requires specialized laboratory infrastructure. It takes several days, and most importantly, interpretation of staining patterns still depends on the pathologist. Immunohistochemistry and interpretation require ongoing training and quality assurance. Every diagnostic test has two consequences. It provides information and it influences patient behavior. Additional tests can cause patient anxiety. It is very important to consider the mental health factor too when implementing newer tests. Your patient may visit you more frequently or may even ask for a hysterectomy, not because the evidence demands it, but because of the fear. Additional tests can also trigger a cascade of further investigation procedures. Unless each step clearly improves the outcome, we risk increasing healthcare cost, patient anxiety, and the burden of the unnecessary follow-up without a proportional clinical benefit. Now let's move from the laboratory to the real world. When we talk about cervical cancer elimination, what does the WHO emphasize? We all know about 90-70-90 rule. WHO elimination strategy focuses on three things: HPV vaccination, HPV-based screening, and HPV treatment of the precancerous lesion, timely treatment. Now, kindly note here that biomarkers are not among the central pillars of this WHO elimination strategy. Why? Because a clinically useful test should not only be accurate, it should also be affordable, accessible, applicable, and acceptable. Why liquid biopsy is not a game changer in cervical cancer? When the tumor is right in front of us, visible, easily accessible, why should you look for it in the bloodstream? We already have cytology, HPV testing, colposcopy, and directed biopsy that provide direct tissue assessment. Blood-based testing adds cost without clear advantage in the routine clinical practice. The global trend in cervical cancer screening is shifting towards HPV self-sampling kits. Why? Because it overcomes barriers such as embarrassment, lack of access, lack of time, shortage of healthcare providers, thereby improving screening coverage. But here is the important point. Self-collected samples, they're excellent for HPV detection. However, they're not routinely suitable for biomarker assays like dual staining, which require cellular morphology and laboratory processing. I would like to ask you a question. How many of us can confidently tell our patients exactly which laboratories in our own city are offering these biomarker tests without, with standardized reporting? Hardly few. That's exactly my point. Availability is inconsistent across the laboratories and healthcare settings. And even in those places where it is available, there is no uniformity in the pricing. Two patients living in the same city may receive the same test at very different costs. After highlighting these limitations, let me also acknowledge where biomarkers genuinely add value. Resolving equivocal diagnosis. In borderline or ambiguous cases, biomarkers improve diagnostic confidence. Secondly, biomarkers have significantly advanced our understanding of HPV infection, cervical carcinogenesis, and disease progression. They continue to be invaluable research tools. We live in a world where millions of women still lack access to basic cervical screening. In such a setting, investing disproportionately in increasingly sophisticated biomarkers risks perfecting the margins while neglecting the fundamentals. Biomarkers undoubtedly have value in selected cases and in research setting. But before they become routine clinical practice, they must demonstrate that they are affordable, they improve patient outcome, they are standardized, and they can be implemented at a population level. I would like to conclude my debate by saying that biomarkers are a scientific boon, but not yet a public health boon. For countries like India, they risk becoming more of a bane than boon. Thank you. I thank my mentor Sundari ma'am and Jyoti ma'am for this opportunity.
Thank you, Dr. Tejaswini, for your excellent talk. I would now request Dr. Veena to give her expert comments and opinion on both the talks we've had so far.
Thank you, Dr. Tara. I think it was a wonderful debate. I wish Dr. Nandisha had seen the topic properly. The topic given is biomarkers in cervical cancer screening. Not the therapeutics part of it. That is one point about his. Otherwise, he also spoke very crisp and clear. But I think Tejaswini wins the debate heads on. There's no doubt at all. What she says really makes sense here. Like in country like ours, where we're still struggling to use, HPV testing also. Like we're still in VIA area. We're not even gone beyond VIA in many areas. Only recently we've had political support in terms of HPV vaccination. So the people are waking up to the problem of cervical cancer. So this is the time we should speak about at least implementing HPV DNA testing. Okay, going beyond that to biomarkers is, I think it can be done only in exceptional situations where fertility preservation is extremely important. Very young women where we don't want to do, ablative or excisional procedures or hysterectomy. Of course, older women will request for a hysterectomy moment they know there is some risk of cancer. That is how our population is. I totally agree with Tejaswini on that point. I would like to tell one thing, WHO has changed the recommendations completely about HPV DNA. There is a manual which has come up just last month, in the month of May 2026, where they say any HPV positive, go and ablate. No need to do anything in a facility like ours where there is very poor follow-up and resource poor countries. It doesn't recommend anything, neither dual staining nor extended genotyping, nothing. So, super.
Please mute yourself, whoever is talking. Please mute yourself. Doc Dr. Veena, yes, please.
Yeah. So I think we should just remember that we should totally invest in at least testing women. I think self-sampling will go a long way for us. Biomarkers is not going to come in near future to our country, at least. Even in institutions, I don't know how many of us can talk about biomarkers being utilized. In maximum, we use this Ki67 and P16 here. Methylation and all is a distant dream. When you gave a talk about methylation, I told in an alternate universe, probably we'll be doing all these things. As of now, in our country, it is not. Some countries, it has been accepted as a routine, caring pathway, but not in our country. I'll totally go with Tejaswini in this particular regard. Anyway, congratulations to both of you for a fantastic debate. It was extremely interesting.
Thank you, ma'am. Thank you for your valuable inputs. Now we'll move on to the next session, for which we are waiting. It is a panel discussion which will be moderated by Dr. Sundari N, who is retired professor from MS Ramaya Medical College and currently consultant at Kanva Diagnostic Center, Along with her, we have Dr. Padmashri R, who is the head of the Department of OBG, and she's a medical superintendent at Sri Madhusudana Sai Institute of Medical Sciences, Muddenahalli. So the panel discussion is on evolution of cervical cancer screening. So the panelists for this program are Dr. Parimala Devi, she's a senior consultant at Fortis Hospital, Dr. Padmakshi, who is a senior consultant at Cambridge Hospital, Dr. Sheila H.S., who is the head of the Department of OBG from Dayanand Sagar Institute of Medical Sciences, and Dr. Vijay Lakshmi, who is the head of the Department of Cancer Biology and Molecular Diagnostics from Cancer Institute, Chennai. Over to you, Dr. Sundari Madam and Dr. Padmashri Madam.
Hello.
Hello, Madam.
Hello.
You're audible.
Good
You're
evening.
audible,
I'm
madam.
audible?
Yes,
Yeah.
madam.
Thank you, the organizers, Dr. Jyoti, for giving us this opportunity. Anyway, I think we have very short time to do it. We have extensively heard about the biomarkers. Only thing is, it's as Dr. Veena put it, there is a confusion for us. Which biomarker? Already I saw one question in the chat box. Which biomarker, where and when to use it? That's exactly because there is a surge of biomarkers now for us. And we can speak all those things. Tejaswini has put it very rightly that where to use how, affordability, accessibility, and this one availability. We have to see that's number one point. But we go practically if we have biomarkers with us, when to use and where to use. That's what I think we will, at the end of this debate, panel, we will have a clear idea clinically how we use these biomarkers, which are available with us in our places, working places. And I request Dr. Padmashri to take over and start the panel.
Thank you, ma'am. Ma'am, you're sharing the screen. Can you move the slides?
Yeah, there is a screen is shared. Yeah, you do it. It's happening, no? It's good.
Yes.
Yeah, Padmashri, go ahead.
Yes. So, as it has been mentioned by the previous speakers, there has been a paradigm shift in cervical cancer screening from just microscopic cell-based study to molecular methods and now AI assistance. So, we'll move on to the panel because we are a little short of time.
Can you come on the video, madam? Padmashri, madam.
Yes.
Yeah, that's nice.
So the first question I will ask Dr. Parimala, a quick look from 1940s to 1990s, pap smear was the gold standard for cervical cancer screening. And the question is, what were the strengths and blind spots of cytology-only screening? And which women were most likely to be missed or over-referred? And what is the role of cytology in present cervical cancer screening? Parimala, ma'am.
Yeah, good evening all, and thanks for this question and for the participation, Dr. Sundari madam and Padmakshi and Dr. Aruna madam. See, as said, pap smear is the gold standard. Like since our practice, we have started since nearly 35 years. We're all doing this pap smear. It's just the one common test which everybody knows when it comes to screening. Because it has been reducing nearly 60 to 70% of cervical cancer in developed countries where a system is followed. In ours, it may be opportunistic. Because it is going to give us, it is a simple, inexpensive, and also non-invasive test. And it is actually, we can screen lot of big number of population screening can be done with this test. And it is suitable for all to detect the infection also, and also pre-invasive lesions also we can see with this pap smear. Even though the specificity and of this test is less, actually, the specificity is 90% and sensitivity is 65%. But there is always a unsatisfactory reports which are about 6 to 10%. But still the negativity can come up to 20%, and also the false positivity can be 5 to 10%. With all these things, actually still it has got some setbacks like this. Still it is available in most of the places, and patient usually is convinced because it is can be done most of the time when they come to us for the other consultation like that. Pap smear, even though in the triaging we may depend on other tests, pap smear has been one of the important tests we are depending. I would say that even though the further we may have to use other tests to do the triaging and all.
Thank you. I think I request all the panelists to be very crisp, and then to the point, so that because we have very short time left with us. Yes, Padma Shri, please go on.
Yes. So the main issues with PAP screen is that there are false negatives, inadequate sampling, and reproducibility problems. But we cannot deny that its usefulness in helping to reduce the cervical cancer burden in many countries. So going on to the next question, this is for Dr. Sheila. A 35-year-old woman presents with routine cervical cancer screening, no prior abnormal cervical screening history. She's asymptomatic. She's done a primary HPV DNA test. HPV 16 is positive, 18 is negative. Other CHPV is negative. So the question to you would be, what is this limited genotyping? And what are the other types of genotyping? What is CHPV and its risk stratification? And in this case, what is the next best step for treatment?
Thank you,
Dr.
Padma.
Sheila.
I'm Sheila here. Depending on the availability, the HPV test may provide that is 4 types. One is no genotyping, which means individual genotypes are not identified. It is aggregated positive or negative results for 12 HPV viruses, genes. Next is a limited one where HPV, that is HPV 16 and HPV 18 can be detected individually or combined. Sometimes even that is HPV 45 is included. The other rest 10 HPV types are pooled and the results is given. Next is extended genotyping. Here there is individual or combined results for HPV 16 and 18 and individual or separate, combined for 16 and 18 and 45, and the rest 10 are grouped into 2 or 3 groups, pooled and given the result. Next is a full genotyping where individual carcinogenic, that is 12 carcinogenic HPV viruses are identified and the results are given separately. So the next question which you asked is, the HPV, the risk stratification. The WHO target product profile groups these 12 HPV viruses into 4 groups. It is 1A, 1B, 1C, and 1D, depending on or based on the prevalence of these in cervical cancer. This is a risk stratification. Group A contains HPV 16, which is as the highest risk. It is found in 60. That is, it causes 62.4% prevalence is there. And group B is 18 and 45. That is 20.1%. And group C is 33, 58, 31, 52, and 35. There the 14.5. And group D is 2.1. The next question in this, what is that question you asked? Yeah. Here we know what is the limitation of this HPV DNA test, just like that. It is a it has a low specificity and detects both transient and persistent infection. So 90% of the women do not develop, that is cervical cancer, and there is unnecessary anxiety over intervention and over treatment. The next. Yeah. So what is the next best step? That WHO recommends this limited and extended genotyping. Here it is this slide shows that is a high flow capacity where about 60% of the population undergoes the complete evaluation. That is a treatment, the triage, that is screening, triage, and treatment. So here, the next one is a low where it may undergo, that is the population undergoes less than 60%, where they may have one or the other. That it may be only a screen and treat or screen and triage treatment. So the next slide. Yeah, then in this case, the case which you are given shows limited genotyping. Limited genotyping, here it is HPV 16 is positive and HPV 18 is negative and the others are all negative. So which is of a high risk. So according to WHO, that is, what is that? We should directly go in for colposcopy and treat. So here, yeah. Yeah.
So in WHO, what he says is that directly 16 is directly for colposcopy, or it can go via cytology and colposcopic impression and treat. It can be by ablation if it is seen completely the transmissional zone. Otherwise, we have to go and do colposcopy and go ahead with the LEDs and or LEAP.
Okay, thank you, Dr. Sheila. Going on to the next case scenario, we have been talking about dual staining, that's P16 and Ki67. So one question on that. A 36-year-old multiparous woman attends routine cervical cancer screening and no previous abnormal cervical screening results. Her primary HPV DNA genotyping 16 and 18 is negative. However, 52 is positive. The clinician has performed a dual stain for her, and the dual stain has come positive. So this question to Dr. Padmakshi, what is dual staining and how does dual stain differ biologically from cytology? Dr. Padmakshi.
Good evening, ma'am.
Good evening.
Dual staining is an immunocytologic chemical test that simultaneously detects P16 and Ki61 in the cervical epithelial cell. Their co-expression is abnormal and indicates HPV-driven cell cycle dysregulation, identifying transforming infections rather than transient HPV infection. Dr. Vijayalakshmi would like to talk about this slide.
Yes. So this is one of the very specific biomarker tests that is available right now, and it is involving two very important biomarker. One is P16 and one is a Ki67. Ki67 is a proliferation marker and P16 is a senescence marker. So what happens is any cell which is going to be expressing both in the same nuclei goes to show that it is involved with HPV. That is, P16 is a surrogate marker for HPV infection in cervical cancer, and then that means, and the cell also has got transformed. There is a displace. Normally, P16 is a nuclear protein. It is supposed to be expressed in the nucleus, but during the transformation, there will be a change from the nucleus to the cytoplasmic expression. So when you have a cytoplasmic expression of P16 and Ki67 in the same cell, then what happens is, and they are actually, the test is made in such a way that they are colored with the two different chromogens. Like Ki67 is AEC and I think P16 is DAB. So you have two different colors. So when you have the same, that is the brown cell, which you can see under the microscope, you don't need a very trained cytotechnician also to see. So if you just see a cell which is like a dual stained, a brown color cell, that means the transformation has happened. That is why it adds to the specificity, because the test has been made very beautifully, and therefore this is why there are several studies which have shown the specificity of the dual staining to identify the ascus and the CIN lesions, and that is why we have this particular test as one of the most important tests recommended by WHO for triage.
So correct. A dual expression in one cell of both P16 and Ki67 is clinically very significant.
Yes.
So I think we've covered what would be when we have to do the indications for doing a dual staining was covered in the debate, and the sensitivity and specificity was also mentioned. So can we go to the next slide, ma'am?
Yes.
Please.
Yes. So a quick summary for that patient, Dr. Padmakshi. What would we like to do for this patient? She's
she got
52.
HPV 16, she is negative. 18, she is negative. But she has HPV 52 positive. So in this case, HPV 16 comes in the WHO 1C category. So we have to treat immediately because there's a 14% risk of cancer. So we would advise her to go in for colposcopy. And once the colposcopy report is seen, we would continue to repeat HPV surveillance for her, treat according to the report. And when she comes HPV negative, no, that's it, ma'am, for her. Anything?
Next slide. Padmasree, next slide.
So the question now is what the dual stain guidance actually changes. So it changes, it causes 12% fewer total colposcopies versus just doing cytology triage or going with HPV positive results. So that's the aim of doing a triage and add-on. You can end up doing fewer tests and fewer treatments for the patient if we go for the triage, especially when it comes negative. Next slide, ma'am.
Just to put in a word, ma'am, HPV tells who is infected. Cytology tells us what the cells look like, but dual stain tells us whether HPV is causing transformation. Thus, modern screening becomes increasingly biology driven rather than morphology driven.
Very
Yes,
right,
ma'am?
Dr. Padmakshi. So the next question is, can LBC with dual staining be used for routine screening? Dr. Vijayalakshmi?
Yeah. So, yes, LBC with dual staining can be used in routine screening. It has been happening in other countries. WHO recommends it as well. But for a country like ours, this dual staining test, P16, Ki67, is still very, very expensive. One test is, I think, nearly close to 2,500 to 3,000 rupees. And the availability of the test also takes a while. And it's an imported kit which has to come from the US. It is marketed by Roche. So therefore, availability of this test is little difficult for a country like ours. So therefore, that's the difficulty. The cost is an important factor. Availability is an important factor. But yes, if it is there, then it can be routinely used.
Okay, so we go into the next case scenario, which is what we commonly see. So this is a 30-year-old unmarried lady who comes with a pap smear report which says HCIL, and a colposcopy and a biopsy is done, but the biopsy shows CIN2. So how will we manage this situation next? Dr. Vijayalakshmi?
Yeah. So the CIN2 is a very classical area of, the gray zone of pathology, where we don't know this. The CIN2 can regress, can progress. So one wants to understand, but still you cannot ignore because the report is HCIL and CIN2. This is where, WHO also recommends a biomarker-based triage will be extremely useful. So for this kind of a patient, if we do this P16 and Ki67 dual staining test, so that would exactly let us know if that is positive. That means she is already transformed and she will need a treatment, which can be either ablation or LEAP based on her transformation zone visibility, but it has to be done. So whereas if the P16 is negative, P16 Ki67 is negative, then one can probably do her HPV testing, and then based on that she can be followed up. So therefore, this is the kind of a classical situation where biomarker-based triage is very useful.
Can I say something here, Dr. Vijayalakshmi?
Yes.
Anyway, we have a biopsy specimen there. Can we do IHC-P16 in
Yes,
these
yes,
cases?
we can simply do. Yes, definitely,
Yeah,
ma'am. So because
instead
we
of
have a
going
thing, we can
again
do
for
a
the
histology.
dual
Yes, yes.
test.
We can
Yes.
do a histology. P16 can also be very easily done on the specimen. And
Yes.
then if P16 is positive, then you know that,
Yeah.
it is a surrogate marker for
That's an
transmission.
implication is, Padmasree, can I have the next slide? Go to the next slide, please. Yeah, this is always said. CIN2 is not a lesion to be treated automatically like CIN3. We have to have this because now that it is a HSIL and LSIL by the histology also, when it gives is a HSIL favoring CIN2 or 3, CIN3, straight away we go for the treatment. When it is CIN2, it's always, especially in younger women, WHO recommends in a younger woman, probably it's better to go for the biomarker, that is IHC-P16 is the same specimen of the biopsy we could do. Next slide, please. And if she is positive for the IHC-16, we have to treat her as a CIN3 lesion. And if it is negative, probably it is CIN1, we can treat her as CIN1, like with only surveillance, but no active intervention. Yeah, thank you. Next slide. Please go to the next slide. Next question, Padmasree, please.
Ma'am, I think, yeah.
Yeah.
So, another quick question. A 35-year-old woman, she has no history of abnormal cervical cytology or postcoital bleeding, but she's undergone a primary HPV screening using Aptima. HPV E6 E7 mRNA assay. So next slide. Ma'am, I think you have to click on it. So the question is, she has done HPV E6 E7 mRNA result. So it has come positive. So what is the significance and what would be the appropriate next step in the management? So this
Yeah.
question to Dr. Sheila.
Yeah. Thank you, Padma, again. As we already heard Dr. Jyoti speak, it is a E6 and E7 gene which binds and inactivates the tumor suppressor protein, that is P53 and RB respectively, causing disruption in the normal cell cycle and also apoptosis. So this promotes what? Transformation and proliferation. So first is a transcription and next is the translation. So there is transcription of viral DNA gene to E6 and E7 mRNA expression by active virus. So when there is a presence of E6 and E7 mRNA virus, the test which detects it says that it detects transcriptionally active infection. It is nothing but an oncogenic driver. So next, it is more specific when compared to HPV DNA test, because that HPV DNA test tells both a transient and as well as active infection, and it is more specific, which is already told here, and it expresses the protein, which is it is active infection is going on. Next.
Yeah, the sensitivity is, however, slightly lower.
Yeah.
Yes.
But
I think
specifically
Dr. Vijayalakshmi, would you like to talk on
Yes.
that?
So I think mRNA test, the sensitivity compared to the HPV DNA, the HPV RNA test basically is more specific compared to the HPV DNA. But one thing is the HPV RNA test cannot be used on the self-collected specimens. The HPV DNA now it can be used for self-collected specimens, whereas for HPV RNA it has to be clinician collected specimen only. And second thing is for a routine screening program, it is still a little difficult to use an RNA-based assay because the collection medium, the RNA is very, very labile. It's not so robust like DNA. So RNA, if it gets degraded, then the assays will fail. So you need to have a proper collection medium which will preserve the RNA properly for us to perform the assay. So that as of now, we are having difficulties. So the thin prep collected specimen seems to work, but so therefore there has to be a universal medium for RNA. But definitely compared to DNA, this is a more specific assay which can be used and maybe in a triage situation. Thank you.
Okay, so what do we do with this patient? How do we manage? There's already...
It should go directly. Yeah, what I know is it has to go for colposcopy and treat. Yeah.
Okay. So is there any role for HPV genotyping? Because in this case, there was a primary E6, E7 assay which turned positive.
No.
No.
We will be spending little more money on the genotyping.
Yeah.
Instead, we can straight away go for colposcopy, ma'am.
Colposcopy, yeah.
Okay. So yes, we've come to the final case scenario. This is for Dr. Vijayalakshmi.
Please ask the organizers, do we have little more time?
Do we have time?
We are exceeding? Do we have time?
5 minutes.
5
Yeah.
minutes.
Okay. Thanks a lot. Thanks a lot.
Right.
Padmasri, please go ahead.
Yes, a 47-year-old woman presents with persistent postcoital bleeding. On examination, a friable cervical mass is seen. Biopsy is performed. It shows invasive squamous cell carcinoma of the cervix. So, Dr. Vijayalakshmi, I think you have experience in PD-L1 IHC. So, can you tell us how this helps us?
Yes, ma'am. So this PD-L1, as we saw in the previous lectures, also stands for the programmed death ligand 1, PD-L1. It's basically a biomarker which can be identified in women to identify women who are more likely to respond to immune checkpoint inhibitors. So therefore, it is basically an IHC kind of a staining. So there is a particular assay which is called as the 22C3 based IHC, and then you give a CPS score, which is called as the combined positive score. So there is a kind of an equation that we see. So you look at how many PD-L1 positive cells are coming up, Plus, you also look at the PD-L1 expression in the lymphocytes as well as in the macrophages, and that you multiply into 100 with the total number of viable cells. So that will give you a CPS score. So what happens is that the maximum CPS score that you can get is basically 100. And you also have to take care that only the viable invasive tumor cells have to be the denominator. And you have to look at the membranous staining of the tumor cells for the PD-L1. So if you have your PD-L1 score less than 1, that means the patient is not eligible to get immune checkpoint inhibitor, more so in case of cervical cancer, the pembrolizumab. Whereas if the score is more than 1, then the woman becomes eligible to get pembrolizumab. And if the score is greater than in 10, then the expression is high, and if it is 20, it's very high. So that means based on the PD-L1 staining, we can decide whether the woman will respond to pembrolizumab, or there are also other immune checkpoint inhibitors that are in trials like nivolumab, sometimes a low dose nivolumab. All these are already in trial, but one needs to do the PD-L1 staining to understand who will respond and who will not. That is where this becomes important.
Great. Do we have time? One quick
Just
question on liquid biopsy and low invasive future pathways. I think Vijayalakshmi, madam.
Yes.
Yes.
So,
can you elaborate on this?
very quickly, I will tell you, liquid biopsy actually is extremely useful, especially in the recurrent cases where, whenever there is a tissue is becoming an issue, then liquid biopsy comes into play. And
I think in lung cancer.
more than cervical cancer, there are other cancers in which liquid biopsies become like a bread and butter, like lung. For every lung cancer patient, the liquid biopsy is very useful for disease monitoring and for getting your targets even to start treatment, because by the time you take a tissue and then you do a biopsy, the liquid biopsy is very easy to get. And for any disease monitoring based assays, liquid biopsies based NGS works beautifully. Another experience is that instead of doing tissues, we have found that even the cervical exfoliated cells that you get from the patients, one can do NGS on that. Next generation sequencing can be done on that, and then you can pick up what mutations are coming up in these women, and then we find that many of the cervical cancer women have a lot of P10 and PIK3CA coming up, and all this can be done with the exfoliated cells itself. You don't even need a tissue. So that way, the biomarkers these days, because of the technology, it can be accessed with even scanty material. Any body fluid can be used as a biomarker. You can pick, because we have the technology to do that. And now going forward, we cannot say we won't use biomarker, because we are all moving from morphology based risk stratification to biomarker based risk stratification. As and when that's how the technology is going. So these biomarkers are definitely useful. Even the urine based assays, there are several studies where HPV has been studied in urine, but then again, the collection, people have shown that the Colli-P based collection seems to work the best. So we just need to standardize the entire protocol properly. And once the entire protocol is standardized properly, then it can be done in any lab. So that's how we started HPV DNA. Initially, they said HPV DNA cannot be done. You need very special expertise. But now it's become like, without HPV DNA, there is no cervical cancer screening. So in few days, without these biomarkers, we will not be able to run these kind of screening programs. We are heading there very shortly. That's my take on biomarkers. So biomarkers, we cannot ignore. They will help us in our management.
So I think that, Dr. Vijayalakshmi, you answered the last question. What is the future of biomarkers in clinical practice in India? Sundari ma'am, do you want to add on to that?
No. It's. I think we'll wind up. Yeah.
So that's the take-home
only thing
message
is,
from this
whatever
panel.
is available with us, main thing is, as WHO said, whatever be the test you use, but be doing the screening, as Dr. Aruna Nigam insists on that, be doing the screen, whatever is available. But now the biomarkers are wherever there is a feasibility, possibility, and availability, judiciously we have to use the biomarkers to improve our diagnostic accuracy in the pre-malignant lesions, and then do the accurate treatment for the patient, not the over treatment, not the under treatment. That's what I think we wanted to give the message through this the panel. I think we have done to a certain extent. Thank you very much again. Thank you organizers for giving the extra time for us, and we are sorry for taking a little more time. Thank you. Thank you the panelists and Dr. Padmasree for a wonderful panel conduction as well as the participation. Thank you all of you.
Thank you.
Thank you, Sundari
Thank
madam.
you,
You've taken a lot
everyone.
of trouble.
Thank you,
along with
madam.
Jyoti. Thank you so much.
Thank you so
Thank
much.
you, Thank you, everyone.
Thank you, ma'am.
So this interesting webinar has now come to an end. And thank you, Dr. Jyoti, for conducting such a nice webinar on an interesting topic and framing the program so beautifully, like nice lecture, thrilling panel, and a very good debate. Thank you so much. And now we will be meeting next month, 7th August, with an other interacting and interesting topic like colposcope. We have hello. Hello.
Yeah, Nidhi, we can hear you. So the next month, it is on 7th of hello, can everybody hear me? It's on 7th of
Yes,
August,
audible.
7 p.m., 70 minutes. It's on quality assurance in colposcopy, and none other than Dr. Dipanvita Banerjee from CNCI Kolkata. They will be steering the next month session. So this is for today. And Dr. Jyoti, excellent webinar. Such wonderful panel by Dr. Sundari and her team, and Dr. Vijay Lakshmi. Such wonderful inputs. Debates were excellent and crisp, and I think everybody enjoyed. We had a great attendance, up to even 120 delegates had joined. So all of us had a great take-home message.
Excellent webinar, Dr. Jyoti. Really creditable to you and finishing in time.
Perfect.
So that all the who were there since the start are still here. So amazing.
Worried about
Amazing.
it.
I must congratulate you.
Yes, very nice. So see you on 7th of August with another interesting webinar on quality assurance in colposcopy by Dr. Dipanvita Banerjee. Thank you.
Sorry,
Thank
I
you.
got actually, I don't know how I've left the meeting. I was not knowing that I am speaking or not, and you people are audible or not.
So we could understand. Thank you so much, Didi.
Okay.
Bye.
Thank you. Wishes to all of you.
Thank you,
Bye.
everyone.
Bye-bye.
Thank you for the
Good night.
opportunity, Dr. Aruna
Yeah.
and Dr.
Thanks for the
Bindya.
opportunity. Thanks for the opportunity.
Ma'am, it's our pleasure. It's our pleasure
Pleasure.
for sharing the wisdom. It was really nice.
Thank you.
Bye, ma'am.
Thanks
Bye.
a lot, Bindya and Aruna and Jyoti. Thanks.